Well, thank you for the opportunity to speak for a few minutes. I saw the question for this has to do with pulsations and the abnormal pulsations, and then I realized also we're talking about CSF disorders, so I kind of put the two together and want to talk a little bit about posterior pulsations in the Chiari malformation and studies we've done to look at that, and also how this might interface with other CSF disorders and how we can kind of perhaps start to put all that together. I'd like to acknowledge to a very great extent the engineering group in Akron, who actually is helping us develop these really important tools to examine more quantitatively and more dynamically the movements of CSF and brain in the posterior fossa and the cervical medullary junction. It's these guys, Frank Loth and Bryn Martin, and their group, and collaborators with them that have helped us through MRIs at the clinic and our patients to take a closer look at what's going on in the posterior fossa. And this talk, to a great extent, is really about just the development of that that information. And a lot of it's very familiar to us, but to be able to quantitate it and look at it will be important. It's really up to us to take this information, look at these measurements, and find out if they then reflect important things that are going on clinically with our patients. Some of these patients also came from Ohio, Cincinnati, Dr. Tu, and were funded by NIH and Concord Chiari Foundation for Dynamic Motion, and I have no disclosures. So we all, again, I heard the word preaching to the choir, we all have been to some great extent frustrated with the lack of correlation between just simple anatomy and the ways that the Chiari present and their symptoms and how they respond often to Chiari decompression. Here's various forms of MRIs. But we also know that, well, since Gardner and Williams, that there has been the CSF movement hypothesis in various forms that discuss both the tonsillar migration and also the syrinx development. And also we know that CSF movement's involved because of acquired Chiari, that just fluid leak from the spinal canal can produce a Chiari that looks essentially identical to some of the simpler forms, I should say, of Chiari malformation. So being frustrated with this, we often look to CSF movement and ask, is there some variable there which also may be helpful in separating these patients? In doing that, we need to be reminded that the CSF movement here at the cervical medullary junction is really a function of what's going on in the whole cranium. It has to do with the compliances, the volumes of fluid that go in and out, the volumes of blood that come in, everything from cardiac input to the cranial environment affects what's going on at the cervical medullary junction, how much fluid under how much pressure with how much pressure differential is occurring at this junction. So that comes down from the top and, of course, may play a role in what's going on there in this dynamic motion. We see this, of course, through our CineFlow studies, and all of us have had patients that come to us and ask, when am I going to get my CineFlow study? We try and quantitate not only crowding by anatomy, but now also ask the question, can the CSF flow be some sort of sensitive marker for crowding? And I'm not sure how the people around the room have felt about this, but I've been less than impressed with the amount of additional information I've gotten from CSF flow studies. They're hard to quantitate. They show flow in only certain very limited ways. So to be able to say that you need surgery and you don't based on a CSF flow study, I think is not very helpful. There's a lot of things, as I mentioned, that change CSF flow at this junction. And another way to look at the CSF flow is to ask, well, what we're really asking is about crowding and about the resistance of flow at the cervical medullary junction. So it's really about resistance or engineering-wise, a more general term, impedance of flow at this junction. Can we measure a more integrated, perhaps more reliably or reproducibly measure of what's going on than CSF flow at one plane, one direction, and so forth, if we measure impedance to flow? And so that was one of the projects that we embarked on through MRI, CineFlow studies, not through any major new technology except good time and space resolution, and ask the question, well, maybe if we get an idea of how much impedance, how much resistance there is to flow at cervical medullary junction, it would be a clinically relevant tool. So how do we do that? Well, first you get a very beautiful kind of plaster cast kind of model of the CSF spaces. When I as a neurosurgeon, look at this, I'm humbled by by our small attempts to change the anatomy, and also by the complexity of the CSF space in this region. How can we estimate this with one line or one measurement or even one cross-sectional area? Because it's a summation over a large area of how much resistance there is to flow. So, oops, wrong way. So, and it changes quite a bit from this situation to this situation. Now, this shows the models that can be derived from an MRI on each individual patient's normal and abnormal. From this kind of measurement, we all know we can get CSF flow, quantitation at various levels, and this is done at various levels, and calculations can be made. And for this, I'm going to defer to the engineers themselves. I won't be showing any equations because I don't know them offhand. But we can derive a great deal of information about the resistance, the impedance, and the pressure differentials as they go through the cervical medullary junction. What do we find? Well, this is patients, volunteers, and Chiari malformation patients from 2 institutions. And it shows basically that, there's quite a variety. Average in the Chiari is greater, but the impedance is quite variable from normal ranges up to higher ranges in what we consider to be Chiari malformation. These are all patients with what look like apparent crowding at the cervical medullary junction and ectopia of greater than 5 millimeters. So the legal Chiari, so to speak. So here, I keep going up. Let's go down. What happens after surgery? Well, as you might expect, in many patients, that impedance goes down. We operate really at a focal area of that whole range of impedance that we're measuring. And I was at least personally a little disappointed. It didn't go down very much in many cases. And I'll show in the next slide. That in some cases it actually stayed the same or went up a little bit. Here, though, statistically speaking, pre and post surgery, the impedance goes down significantly and is all greater than in the volunteer group. So we do have this effect on impedance, but I have to say it's not really that impressive. What we did find in the analysis is that we may change the impedance at the area we do the surgery, but there are impedance factors above and below the cervical medullary junction which also play a role. And perhaps we need to think, therefore, that we're not affecting that kind of flow as much as we think. We're not affecting the resistance as much as we think with some of the surgeries we do more focally. And we may need to think over a wider range. It's also true that it's not all about impedance. Many of us have seen in the operating room intraoperative ultrasounds. And the word hammer comes to my mind, but of course water hammer was used about the actual water being the hammer. We think more of the Dr. Oldfield's and Corinne Marasco's reference to the tonsillar pistons. When we see this dynamic view of what Chiari really is in a live patient. And what's striking, of course, is the violence that's involved here, violent striking of the spinal cord. And I don't know, what do you think? Is this enough space? Is this enough movement? Is this too much movement? Is this hyperdynamic? Or is this the right dynamic? Should we be releasing more or not? It's hard for me to tell in this ultrasound really which way to go and how to use this really usefully as a guide. And I don't know if anybody has opinions or algorithms that help them much more, but I have to be honest, I have a very vague algorithm which depends a lot on what I see pre-surgically and clinically and less on what I see here. So I do have theories, though. It's always fun to have theories. And the idea is here is this just a model of what may be happening is if everything's really, really tight, you might have constriction and less movement of the whole system. As things loosen up, and this may occur actually quite rarely, there is greater movement of the tonsils because the tonsils are relatively free in space and flexible, and as opposed to the medulla and the spinal cord. And so as things loosen up, there may be more movement, of course, in the spinal cord, but relatively more due to hydrodynamic effects of the tonsils. This amount of opening and freedom is not enough adequate decompression to avoid the hydrodynamic effects on the tonsils. And therefore, if you open up more, the fluid flows over the tonsils, and you have equivalent movement between the cord and the tonsils. So what we came to is maybe we can't measure the CSF so well, spaces and so forth, but maybe we can measure the relative movement between the spinal cord and the tonsils, and that, in a sense, would be a control within each patient. So it's a question of, does the relative movement between these two parts of the brain, can we use that as a guide to how much hydrodynamic effect there is? Well, we try little experiments in the OR here. We try lifting up the dura, seeing if making more space, that's the idea of a decompression, right? We give more CSF space. If we saw this after decompression, we just lift it up, you say, oh, good, there's lots of fluid space. And so maybe that's enough decompression. So here, I don't know, I've stared at this for several minutes to see, are the tonsil movements slowing down when I lift up? And I can't really tell, but this is a part of our ongoing strategy to see how much space, how much of a decompression results in how much changing of the movement. So this is a model which kind of summarizes, I think, of what we all may be thinking as one model or a hypothesis for what's going on there. And that's cranial anatomy, or crowding, of course, plays a major role. Small posterior fossa, things pushing down on the tonsils from above. Everything that's going on in the cranium and its anatomical initial starting point at the cervical medullary junction, it creates an environment of a certain amount of impedance to flow at the cervical medullary junction. This is powered, though, by a pulsatility, which is a craniospinal pressure differential created by the vascular system, cardiac driven. So this is the engine which flows through this system, which has a certain impedance and causes CSF flow. So it's those two elements combined which help us describe what's going on at the cervical medullary junction. This, of course, can cause CSF flow, or it can also cause the tonsil movement and deformation, and to some extent the brainstem movement. Now, what happens if you increase the crowding in any way? You increase the crowding, you may decrease the CSF flow and increase the tonsillar movement. And of course, if you change the pulsatility factors, you may also increase CSF flow and or tonsil movement. So those are the factors involved at this point. And at least theoretically, it can promote over time more tonsil impaction, and maybe is part of the tissue injury and symptoms. This is speculative as to whether this chain of events affects, but we have some evidence that this might be the case. So now we have the idea of movement and the idea that the tonsils can be battering the spinal cord. We all know the anatomy sometimes is where the tonsils move this way, parallel to, sometimes they actually hit the spinal cord. We've seen snow plowing effects where the tonsils seem to be pushing on the dorsal spinal cord and having a snowdrift, if you will. So we know that this can impact over time and have various effects. However, we still get patients. And these patients come to us with headaches, and these two patients came to us with headaches and syrinx and tonsillar herniations down to just the upper level of C1 in both cases. And in one case, we opened up and see, in a sense, almost, I'm sorry, I kind of went away there, but you saw it had very little movement. And the next case, well, let's see, the next case, shows even before we removed bone, we peaked inside below the foramen magnum and C1, and could see even before we've done any decompression, there is movement there of the tonsils. And then with the full decompression, you see the movement of the tonsils and the impacting of the spinal cord. So here's a situation. Both have the same millimeters of descent of the tonsils. Both came with essentially the same symptoms initially. And they have very different dynamics of the cervical medullary junction, very different movement. And the question really for all of us is, does this make any difference? And I can't say that it definitely does in this situation, but I can show you some of the correlations that we found. These are ultrasounds I've shown you so far, but of course, this can be measured even more accurately on MRI. This is a dynamic MRI. Here you see the pulsation of the basilar artery. This is a normal patient, and you see very little movement in the MRI with the cardiac cycle. I can see if I can do this. Let's see if I can do this. I need to get back to my screen for a moment and show you a Chiari patient, and this shouldn't be a shock to any of you. I can't do that. I can show it on my screen. I don't know, is there a way to? Sorry. It looks fantastic. It shows an MRI.
Why is not? 1 second to keep talking.
Basically, the idea is that we know that there's can be more or less movement, and on the MRI it shows it very dramatically. We can measure in the cardiac cycle very clearly. I hope you can get me back there too. Maybe this isn't.
No.
This is an ocean scene.
There's some CSF.
Yeah, this is fluid movement in and out, waves and waves and waves. It's a very dynamic.
I can't do it.
You can't do it?
No.
I apologize.
Let me just get you back on the arm.
Okay.
Otherwise, I'm gonna mess it up. Don't know why.
Afterwards, I'll be happy to show you. I'll turn the screen on.
Wait a second. I can import you in your slide.
No, don't do that. It doesn't, that's why it's out there. It's out there because that didn't work. There's one, I've had trouble with movies, and this one movie has been the worst. The most.
The tonsil's pulsate more or less after surgery?
That's what I'll be showing you.
Oh, okay.
That's exactly what I'll be showing you.
It's behind.
Ah, very good. So now it's there. So in this study, we looked through sagittal MRIs at regions of interest in the spinal cord, the pons, and the tonsils, and we were able to track the movement through multiple cycles, the movement up and down, down and up, and averages, and trace out a curve for each region of interest in each patient. Okay, so now it's changing here, but it's not changing here. I'm sorry. I'm pushing it here, and it's advancing here.
Right and left.
Hmm?
Why? Because the other file is still open.
Mark?
Yes.
Well,
Yeah, yeah.
Can I ask a question?
Please.
Do you have any notion of the changes in pressure due to the pulsatility? In other words, do you see significant momentary increases in CSF pressure? And could these alter the modulus of elasticity of the neurosis?
Mm-hmm. I do have a slide. We do see changes in the differential pressures at the junction with this. And again, I apologize.
How soon after surgery were the postoperative studies done that you demonstrated?
These were within 2 months, I believe. All within about 2 months.
Were they all at 2 months, or did they vary?
Varied with some. Thank you. They varied within some days, but rarely more than 3 or 4 days. It's just for practical scheduling reasons. Okay. Yes. I appreciate it. Thank you.
Your
Okay.
setting, keep resetting.
Yeah, sorry about that. This is old presentation view, which messes us up. Here are some of the correlations. I'm going to go back. So I mentioned here, that's where the trouble started, that we look at the ROIs of these areas. And here you see the Chiari patients have a wider range of tonsillar movement and also more in the negative range in terms of downward pulling. Than compared to the controls here in blue. And after surgery in green, we see somewhat normalization. That's shown in graph form here. We looked at spinal cord, pons, and the tonsil, which includes the tonsils and some of the body going up. And we see it was with the, oh, look here. It was with the tonsils that we saw the significant difference after, between the Chiaris and the healthy patients, which normalized after the surgery. So we do see bulk displacement that's abnormally high, and it does normalize with the surgery. Here's how we relate back to that old concept of impedance. The higher the impedance that was acting at the cervical medullary junction, the more we saw the tonsils moved, with pretty good correlation, indicating that it's not causation, it's all in the correlation, but it's in the consistent direction. The next question we looked at is neural tissue deformation and its measurements. And that gets back to this idea of the relative movement of the tonsil and the brainstem impacting on the spinal cord, and also the idea that the medulla and spinal cord constitute a pipe or a rope which would be condensed or stretched. And so you can look at 2 different points, the medulla or pons and the spinal cord, to see if it's being stretched or compressed during each cardiac cycle. And here's the analysis of the tonsils. You see the tonsil movement and the spinal cord movement is tracked here, and the difference between them reflects the relative different motion between them and the impact point for them. So we can measure the movement of these 2 and the movement of the tonsils against the brainstem in that way. In terms of strain along the spinal cord, stretching and compression, in a similar manner, we subtract the movement of one area, the pons, with the spinal cord and get the differential movement between them, which reflects both stretching and compression. And this is just an example from the stretching compression. As you see here, there's the Chiari patients have really in the negative direction, and the normals have more in the positive direction, and this changes during after decompression. So just to make the story short in a sense, the tonsil moved closer to the brainstem in patients, and it moved away from the brainstem in controls. The brainstem is compressed in patients and is stretched in controls. This was kind of surprising results because the direction of action was different. With every cardiac cycle in Chiari patients, the brainstem is slightly compressed. And with every cardiac cycle in our healthy patients, it was slightly stretched. Not every, but statistically, I should say. And the tonsils moved closer to the spinal cord, as we expect by the pictures, the impaction. And it actually moved away from the brainstem during the systole and cardiac cycles. Also, what was a bit surprising to us is if we do the analysis and look back and how this movement that we've examined then goes back and affects the resistance or impedance of the fluid spaces, we find that when we do a dynamic model, and this is through computer modeling, we find that there is a feedback where when you take the motion of the tonsils in consideration and the spinal cord, that there's even greater resistance at the cervical medullary junction. So it's a potential positive feedback loop. Let me go back to here. So here you have the model that we had initially, and we see that the movement itself increases impedance and may therefore increase more of the tonsil movement, which can therefore even promote more tonsillar impaction. Tonsillar impaction may then again go back in a kind of a ball valve effect, putting more resistance in the system and increase the movement even more. So how do we speculate on this? Well, let's see if we go to graph, we see that there's more tonsil motion associated with lower tonsils. So the lower the tonsils, again, that there is, the more motion there is, and the more resistance. So it seems to be part of a positive feedback loop. Does the tonsils going down create the more resistance, or does more resistance create the tonsils going down? Well, the answer to that is potentially both, because it's a positive feedback loop, yeah.
Tonsillar bulk motion is in hundreds of millimeters. So, I mean, are you saying that on the ultrasound, the motion is much more pronounced?
No.
It's not physiologic, or are you saying the MR underestimates motion, or what's?
No, that's a deceptive number because that's a small, that's a few hundreds of millimeters per segment. And then it all adds up. Like each segment has a little bit and it all adds up in a larger segment. So I wish I had the numbers for the totals, but that is a per segment. So it does not reflect really the physiological movement. The physiological movement you saw was really more like the ultrasound and that beautiful MRI that I showed you. Yes?
From those ultrasound pictures obviously are obtained in the operating room with the patient with the head flexed.
Yes.
Which is, compounds all the, the narrowing of the area.
Mm-hmm. Mm-hmm.
While the CMRI is most of the times in the head in neutral.
Mm-hmm. That's a good point. Yeah, it's different. So this brings us to the last sort of consideration, is bringing this back to the fact that the CSF pulsations in the first place of course relate to the cranium, and CSF disorders may certainly play a role not only in the initial crowding, but also in the changes that CSF disorders, whether it's hydrocephalus or pseudotumor or cysts or hypotension, can create changes in each of these. And I'll just give some quick examples and then we can wrap up. More motion is associated with, oops, that's going the wrong way again. Here's some examples. Obviously, we know that hydrocephalus can push the tonsils down and cysts can push the tonsils down. That's a change of the initial conditions at the cervical medullary junction. But we also know that changes at the cervical medullary junction may affect CSF circulation, and there's at least hypotheses, this by DeRocca in 2011, that hydrocephalus can cause Chiari, but Chiari can cause hydrocephalus. So the answer to the causation may be in both directions. So the pressure differential and tonsil motion, this relates to the question that was brought up, is we are looking at the differential pressure of the pulsations at the cervical medullary junction. And this correlation was actually quite strong, that there was a strong correlation between how much the tonsils moved and the pressure differentials that we calculated at the cervical medullary junction. Those pressure differentials, of course, are affected by the stroke volume, the impedance, and many factors, but there was a good correlation between those two, indicating that pressure differential obviously is the mechanism, or a very likely mechanical mechanism for moving the tonsils. So hydrocephalus, cerebral cysts, masses, and also cerebral hypertension and hypotension and CSF leaks. We all know that these are CSF disorders which may be affecting the cervical medullary junction. I'm going to give 2 examples. So I'm having a hard time because what I'm seeing here is a little bit different than what I see up there. This is a patient who came to us with pseudotumor and had a Chiari and had initially a venous stenting for the pseudotumor. Had no changes, no surgery, no treatment for the Chiari malformation. And here you see what to us at the time was a surprising decrease in the syrinx. And this again is about 2 months after no, actually this was about 1 month after the stenting of the venous sinuses for pseudotumor. So keeping in mind the differential pressures that exist in pseudotumor and the fact that the brain may be engorged in pseudotumor, and this may affect the cervical medullary anatomy as well, those factors may play a role. But the fact is that this patient has a much improved cervical syrinx, which has stayed stable, actually slightly smaller, over time after a venous stenting, reinforcing the interaction of the cranium and the dynamic system with that syrinx. This is another example. Patient comes to us, typical to all of us, I think. A child, about a 7-year-old, after having multiple revisions at other institutions, came to us with very small ventricles, and this patient was extremely sensitive to malfunctions of the shunt. When the shunt got blocked in those small ventricles, the patient became comatose very quickly. The first observation, of course, we'd all make, especially in this context, is that there's a Chiari malformation. We all know that, makes sense that a tight posterior fossa and cervical medullary junction can increase the sensitivity of a patient to any changes in the pressure and anatomy that might cause at the cervical medullary junction. Another thing we noticed when the patient came is that their previous MRI looked like this. So they did not have this Chiari all their lives. This was not a congenital Chiari. In fact, part of the treatments, as I listed down here, part of the treatment for the difficult hydrocephalus was a lumbar shunt as well. So the patients had a ventricular perineal and a lumbar shunt. That resulted in the Chiari, and it also greatly increased their sensitivity to shunt treatment. What we did is we removed the lumboperineal shunt, and this is 4 months after that removal. You see an improvement in the anatomy, not a total resolution. There's an improvement in the anatomy after removal of the shunt. And also, I think importantly, clinically, the patient became much less sensitive to any shunt malfunctions or changes in shunt function, and hasn't required a surgery for that since that time. So this just reinforces in these cases the interaction between cranial dynamics and changes you may make up there in the clinical picture and Chiari malformation. So the take home is that this is a tool and that impedance can be considered a marker of crowding, but it likely also plays a dynamic role in the motion of tissue in the posterior fossa, and perhaps also, as we need to determine, make a difference in the clinical picture. It is increased and can be decreased with surgery. Tissue movement is increased in Chiari and decreases with decompression. A positive feedback loop promotes increased impedance and tissue movement. And this is the idea that at a certain point, there's enough congestion and enough impedance that the movement of the tonsils is actually increased and even promotes further impaction. And then that the starting anatomy at the cervical medullary junction and the cranial dynamic factors, as we see changing with CSF disorders, combine to influence the changing impedance and impaction at the cervical medullary junction. At least that's our model. What we haven't done, and I'm sure you've all noticed, is made much in the way of clinical correlation between any of these variables, these dynamic variables, and how a patient's doing. We've made gross observations about Chiari patients' decompression, but not really looking at well, you're moving a lot and you're not. Is there a difference? And this is what we have in front of us, and we're building a the case number and the analysis to see what significance these sorts of changes at the cervicomedullary junction make. Thank you very much. Sorry about the technical.
You had a question? I don't know if you have time for it. Could you go back to the block diagram, Mark?
I will try. Which diagram?
The block diagram with...
The model?
Yes.
Like this?
I'm trying to rationalize my sort of understanding. I guess I'm not sure I understand what impedance means exactly, but I've sort of analogized what goes on at the craniocervical junction to what happens with a garden hose when you put your finger over the end of the hose, and the rate of flow increases, and the pressure increases, and the turbulence increases. So that what happens at the craniocervical junction when the tonsils descend slightly because of the expansion of the hemispheres above, that leads to increased flow, or at least the velocity of flow increases, and the pressure in that region squeezes the tonsils and the brainstem that much more. Does that fit with this? I'm not sure whether this flow is decreased or increased.
I think it is decreased, as we saw, but one of the differences, I think, between the hose and what's going on is some of that transmission of pressure, as opposed to pushing through that impedance and making a faster flow, is instead pushing on the tissue.
Right.
And pushing it down. So instead
Or
of
squeezing it.
Yeah, so instead of your garden hose,
Circumferentially.
you have to have a soft mass in there that instead of forcing its way fast through the small opening that's remaining, it's pushing on the tissue in oscillating fashion.
Right.
And that's why the flow goes preferentially against the tissue and not around quickly the residual.